Hello, everyone, and welcome back to that ninth edition of the annual scientific meeting of the Canadian Rheumatology Association and Arthritis Health Profession Association. We're in Quebec City. We're live. I'm Isabelle Troitsky, and I'm with Arthritis Consumer Experts. You're watching the hashtag CR Arthritis, sorry about that. And we've done a lot of interviews already. Today, I am joined with Dr. Mollie Carruthers. Am I pronouncing it right? Good. So Dr. Carruthers is a rheumatologist at Artus Health Centre in Vancouver. She's a clinical associate professor at the University of British Columbia in rheumatology, and she's clinician investigator at Arthritis Research Canada. Welcome.
Thank you.
So happy to have you here, and we'll be talking about a very specific topic, and there's not so much awareness about it, and it's the IgG4-related disease. So first, I'd like you to introduce yourself. What you're doing, what's your involvement in rheumatology, and this area of focus.
Yeah, thank you. Yeah, I'm Dr. Carruthers, and I trained at Mass General with Dr. John Stone, who did a lot of the initial work in IgG4-related disease. And then in 2014, I moved to University of British Columbia in Artus. And so I have a large clinical practice there, primarily of rheumatoid arthritis, psoriatic arthritis, the usual things that rheumatologists see. And I was able to work with another doctor named Luke Chen, who's actually a hematologist. And he and I have accumulated over 150 patients with IgG4-related disease in Vancouver. So we're one of the largest single centers in the world. So in addition to a busy clinical practice, I also do clinical research and have published papers with Dr. Chen. And now I have 2 clinical trials that I'm running. And that's from seeing all those 150 patients. So with the disease, amongst others who end up not having it. And I would say that, like we're going to talk about, IgG4 is a rare disease and a complex one, and therefore it does make sense to advocate for yourself with your doctors, to see somebody who specializes the disease at your center. Now, that's not necessarily going to be me in Vancouver, and this CRA meeting, we're starting a Canadian IgG4-related disease consortium amongst the doctors. And I would love to have a patient advocate wing of that. I'd love to work with IgG4 patient advocate group. And I think one of our main goals would be to pair people in their location with doctors who are aware of this complex disease and the patients who need their special attention.
Yeah. Excellent idea. So for those out there who don't really understand what that disease is, can you explain what IgG4-related disease is?
Yes. So IgG4 is an immune-mediated condition that causes swelling, glandular swelling, pseudotumor anywhere in the body. That's the problem. It speaks to some of the complexity. So it's going to be hard for a doctor who's only seen one case to give you the standard of care. But generally the way people present are large glands on their face or lymph nodes up here, and then pancreatitis and liver disease. Those are the 4 most common ways that, so people think that they might have cancer, right, with a lump coming out their face, or if they have pancreatitis, there's often a tumor in the pancreas or tumor. We call them pseudotumors. So people think they have cancer, and then they undergo a biopsy, and then it shows this IgG4-related disease. Wait a minute, this isn't cancer. This is actually a treatable immune-mediated condition. And so it's actually good news for a patient to have this rather than cancer, because it is highly treatable. However, you do need to undergo a biopsy because a lot of things can look like IgG4-related disease. So nobody wants to go through a surgical procedure, but it is actually essential for us to get that tissue in order to diagnose the disease.
So you say it's treatable.
Mm-hmm.
What kind of treatments?
Well, the first line treatment is prednisone, which is not my favorite drug. I don't like using prednisone because I call it the bridge to nowhere, right? You start it and then it's really hard to come off it, whether it's rheumatoid arthritis or IgG4-related disease. And then we use things like mycophenolate, azathioprine, some pills, and then we have a infusion medicine.
Yeah. Okay.
And so what we're developing on our research end are pills and also infusions. So similar in terms of the mode of administration. Yeah.
And so does it mean that so there is remission, or is it just
exactly.
quality of life that is just better? Like, can we cure? Can we stop?
Yes, good question. Yeah, I like that question. So I did do a study in Boston that was published in 2015 using rituximab. And in that study, there were 30 patients with IgG4-related disease, and the medication only lasts for 6 months, but the study was for a year, and only 4 people needed retreatment in that year. So sometimes you can put it into remission with an infusion course and not need retreatment. So it is a bit different than rheumatoid arthritis in that way.
Yes.
Once you start treatment, you don't need to necessarily be on it for years and years at a time.
Great, very useful information. Now, I know you had you done last week, I think, a review course on IgG4 related diseases. Are there anything or is there anything that was discussed there that patients would be interested in? Any interesting takeaways for them, or?
So I talked a little bit about the IgG4 antibody itself, which I don't tend to talk about.
Yeah.
I do talk about it with patients. We're still trying to work out, I do tell this to patients all the time, mechanisms of disease.
Yeah.
We don't actually know the cause of most diseases, right? And so that makes it hard for preventative medicine as well. I would love to be able to tell my IgG4 patients, try this diet, do this, avoid this toxin, do these exercises, and then we'll avoid the progression of the IgG4-related disease, or take this 2-week course of antibiotics. But it's not really like that with any of our autoimmune conditions, but including IgG4, that if you don't know what triggers it, then you can't prevent it, if that makes sense.
Yeah.
So what we're working on is, why does this IgG4 antibody become elevated in the bloodstream? Which the reason I was focusing on biopsies is it's not always elevated in the bloodstream, so you can't be over reliant on the blood test, but it's always in the tissue. So this IgG4 antibody is in the tissue when we stain it. We don't know exactly why it's there, and we don't know what triggers it. So in the meanwhile, we're doing the usual that we do in medicine, which is figuring out the treatments before we figure out the cause, unfortunately. Yeah.
And so you mentioned the biopsy to, remove the possibility of cancer.
Yes.
But so how do you find it's IgG4 related disease?
Yes, good question. So under the microscope with just regular staining called H&E staining, they can see features of IgG4-related disease. I don't think I'm going to go into the details of what we see, but I can list them off, but I don't think we get a lot out of that. But so there's some basic features that we can see on a regular stain. So the pathologists do need to be aware of the disease, and increasingly, so I was involved in the pathology consensus paper that came out in about 2012. And so in that paper, so that's over 10 years ago now, most pathologists have read that. And so even before they go to staining for the IgG4, which is a separate thing, your pathologist should be able to recognize it. Yeah.
So awareness is
important. Yes. And in terms of patient awareness, I think it would be hard for a patient to find their symptoms on the internet as opposed to other diseases. I don't mind if patients come to me, they say, Dr. Carruthers, I think I have X disease because I found it online and here are my symptoms.
That happens.
No, I don't mind. I'm open to that. That's great.
Yeah.
There's nothing, we're all just educated people. It's a big, wide world out there. If you find your disease, fantastic. I think when it comes to IgG4, that gap would be a little bit harder since the biopsy is and the blood work and the way it presents is so complex. Even the physician who diagnoses it might have a little trouble managing it but on the end, once you get the diagnosis, then what do? I think that's where the opportunity for patients to really advocate for themselves comes in. Yeah.
Right. And so any insights for patients? Anything you'd like to say to them when they may figure out it might be?
Okay, yes. So if it might be IgG4-related disease, I would say that this is a blessing that it isn't cancer because it is a treatable condition that can go into remission. And we have a lot of different treatments. Unfortunately, not a lot of them well studied because it's a rare disease. So something like rheumatoid arthritis is 1% of the population worldwide. So that ends up being millions of people that you can do these high quality studies and figure out what the best first line, second line management is. In IgG4-related disease, since it's rare, it's harder to recruit for those kind of studies. So as Dr. Allard was talking about, and what I'm talking about, is that Canada does have an opportunity to be involved in international studies of the disease. And so I would ask that patients help us help you. The more information we can get about the disease, the more people who sign up for our studies, then the more that IgG4 can be helped. For example, we do not have FDA, that's in the US, or Health Canada approval for any medications for IgG4-related disease. So even though I did that study on rituximab, that was not brought forward by the company to get the approval. So everything is off-label. So without participation of patients, then we can't get something that gets an approval. The more people we get, the more likely we are to get an approval. And once we get that, then that helps people all over the world. We can say, look at this medication is really working for these IgG4 patients. This is what its side effect profile looks like. And so what I always say to my clinical trial participants, and I've been very fortunate in Vancouver, people are traveling a long way to be a part of my study, so I'm very thankful for that. People coming from Prince George, the island, Kelowna, so all over BC, and volunteering their time and their bodies to be a part of these studies, and it's a real service to others. It's a service to others to be part of a clinical trial.
And so are you working with physicians all over the country to?
Well, I'm trying to build that. Yeah. And so that's what this Canadian IgG4-related disease consortium is about. But at my site, it's been mainly about how did I get 150 patients with it. Boston published on 125, so it's quite a few patients, right? And part of that is that the doctors knew Dr. Chen and I, and then they would refer the patients to us. So that was, but there's no harm if a patient is aware of doctors in their area, then they can say, oh, hey, maybe you could place a referral, just see what this person's doing since they're doing studies. And so if we're doing studies, then it takes it off the doctor's ego a little bit. It's not like, oh, I'm sending you there because you don't know about IgG4. No, never tell a doctor they don't know. We're very egotistical. We get upset, right? So instead it's, oh, well, I heard online that some of the doctors are doing this study, and what do you think if I go see that doctor?
Yeah. Well, that's a good avenue, good approach.
Yeah.
Good. Do we have any questions online?
You mentioned something about access to the treatments and how currently Health Canada is not like FDA and doesn't have anything approved for. We do patient inputs at Arthritis Consumer Experts, and I do not believe I came across any for IgG4 yet. So, in terms of access, while patients are waiting for access to treatments, are there any self-care techniques that they can do at home?
This is a good question. So, unless IgG4-related disease is in the internal organs, for example, if you know it's IgG4 and it's in the glands, I actually will monitor. You don't need treatment right away. This is part of why IgG4 can be good news. So it's not, in terms of what people can do at home, I'm a big proponent of general health. General health will help you with an immune-mediated disease, right? So things like good nutrition, good sleep, good exercise, meditation. These are basic health practices that can lower your cortisol level and help you fight off any immune-mediated condition. But in terms of access immediately, I think one of the advantages of having some people studying the research is that does improve your access, right? Because I have a dedicated clinic time where I see patients, so you're going to move up, in the referral tree for that reason. But I think it would be, so I think I could reassure patients that if you do have it and you do not have organ involved, things like kidneys, liver, and pancreas, that it's okay to do your general health measures, and that this disease can flare and then go away, flare and then go away. A little different than rheumatoid. Rheumatoid's more like this, and then you're always in it. IgG4 can have long periods between flares, actually. Now, I don't treat people between the flares, right? People involved in my studies are all flaring.
Okay.
Yeah.
Well, very interesting. Well, thank you so much.
Okay, thank you. Yeah.
Thank you for your time.
Okay.
Thank you all for watching. I hope you learned great information today about IgG4-related disease. We'll see you very soon for another interview at #CRArthritis. Thank you.